thanks. Good morning, everyone. I would first like to thank the organizers and the scientific committee for the invitation. I'm going to share our experience with irreversible electroporation in pancreatic cancer. This is a technology that I've been using since 2010. We use it in different organs for different indications, but for pancreatic cancer, this is the one tool that we use. Irreversible electroporation use in pancreatic cancer is considered as an off-label use. The technology has been approved by the 510(k) mechanism in the United States, and so when you use it in any specific organ or tissue, that's considered off-label, and that's something we discuss with our patients. So in this talk, I'll quickly introduce you to the technology of irreversible electroporation, and we'll look at the protocol for percutaneous pancreas IRE, patient selection, who would be the ideal patient for this, some case examples, and then we'll look at the data that's out there on percutaneous pancreatic IRE, and then we'll finish with future directions of the technology. So what is electroporation? This technology has been around for several decades. When you expose a cell to electricity, you create pores in the cell membrane, and these pores can be temporary or permanent. Initially, when the technology was used, it was reversible, and when you expose the cell to about 1,000 volts of electricity, you created pores in the cell membrane. And those pores were used to insert genetic material or chemotherapy into the cell, and after a certain period of time, the pores closed. So this was used in cutaneous melanomas and other conditions like that. And the technology was being studied at UC Berkeley, and the scientists there, Dr. Rubinsky's lab, when they increased the voltage sequentially to about 3,000 volts, they realized that the pores that were created in the cell membrane were permanent and they did not close, and that led to the cell death without the use of chemotherapy. And that's how irreversible electroporation was born, and this was commercialized as the nanoknife by Angidynamics. Even though it has the name nanoknife, there's no knife here, which sometimes causes some confusion with your administrators. So this is when the technology was initially introduced. So currently we have the third generation device, which you see on your left. In the middle you see the two monopolar electrodes. You need at least two of these to complete a treatment. You need a positive and a negative. And to successfully complete a treatment, you need to deliver 70 pulses. That's the protocol. You can increase the number of probes to up to a maximum of 6, depending on the size of the tumor. And on the far right, you have the AccuSync device, which is the standard that is used with the nanoknife machine. So what does the AccuSync do? In early human experience, they noticed that given the amount of electricity that was delivered, some patients experienced cardiac arrhythmias. So this is a system that is gated to the patient's EKG, and it detects the rising slope of the R wave in the cardiac cycle. And then it sends a signal to the nanoknife machine, and there's a 0.05 second delay before the energy is delivered in the refractory phase of the cardiac cycle, and thereby reducing the risk of cardiac arrhythmias. The technology, you can use either odd number of probes or even number of probes, and I'm going to show you an animation of how the treatment occurs. And on the bottom of the screen, you see the parameters that can be set on the touch screen of the device. And so this is a little different from your typical microwave, cryo, or RFA that you would use. So assuming that this is your tumor, and you place your 4 probes, and you select the treatment parameters, and the maximum amount of electricity that can be delivered between 2 probes is 3,000 volts, or 1,500 volts per centimeter. And the recommended distance between the 2 probes for separation is anywhere from 1.8 to 2.2 centimeters. If you go more than that, you can have skip areas. You can go less than that, but you're going to get a smaller ablation zone. So once the probes are in place and you confirm their position and you initiate the treatment, now you're going to have the energy 70 pulses delivered between the first pair. And then the machine, once it completes it, it automatically switches to the next pair, and the next pair and completes all the ones that have been programmed. Since you only, the energy is delivered between 2 probes at a time, you can use odd number of probes or even number of probes to complete your treatment. So how is IRE different? So you're used to cryo and microwave and RFA, which are considered thermal ablation. IRE is a predominantly non-thermal ablation. There is a small amount of thermal energy released, but that is not sufficient enough to cause thermal injury. There is a sparing of the collagenous skeleton of the blood vessels, therefore the flow is maintained, so you're able to go near blood vessels, which could be a problem with thermal ablation because of the heat sink effect. And you can also go close to bile ducts, which could be a problem. Again, with thermal ablation, you can cause biliary strictures and ductal injury. There is injury to these cells in the intima, media, and adventitia, but those are quickly repopulated over a period of time. The mechanism of healing, when thermal ablation, you have coagulative necrosis, fibrosis, and scarring, whereas with IRE, the mechanism of healing is considered to be apoptosis. So here's an example of a patient with metastatic neuroendocrine tumor in the left lobe of the liver, and this was treated with IRE. And you can see immediately 24 hours post a big ablation zone, which gradually decreases in size at 5 weeks, and you barely see it at 5 months. So this is something typical you might see more frequently in the liver. This is not a phenomenon that you see in other organs, not very common in the pancreas or in the kidney. So switching gears, we move to pancreatic cancers. These cancers, one of the worst prognosis, second only to glioblastoma. The average survival of these patients is considered about 11 months. Most of these patients are diagnosed in what we call as the stage 3 or locally advanced pancreatic cancer. 50% of them will already be in stage 4, which is metastatic. 40% would be in locally advanced pancreatic cancer, and that leaves about 10% of these patients who would be surgical candidates. So the treatment options for these patients would be, like I said, surgery, 10 to 20%. Vast majority of them would get chemotherapy and radiation. Until probably 10 years ago, the role of interventional radiology was mainly for palliative measures, where you would do pain management or biliary drainages and those kind of procedures. But now you have the option to be involved in the treatment. So understanding the patients who would be surgical candidates would be important when you're in the multidisciplinary tumor board. When you look at pancreatic cancer, you want to look at the interface between the artery and the vein. And when there's a clear fat plane between the artery and the vein, then that person would be a candidate for local surgery. And most of these patients, depending on the institution you work, would probably go directly to surgery. Some centers are now moving towards giving patients neoadjuvant chemotherapy before they send them to surgery, although the data is more robust for adjuvant chemotherapy after Whipple, as opposed to giving neoadjuvant. The two main chemotherapy options for these patients, they will either get FOLFIRINOX, which is a combination of different drugs, or a combination of gemcitabine and Abraxane if the patients are slightly older and the performance status is not as good. In the middle, you're seeing most of the patients who fall into this borderline resectable category, where they're still not resectable, they're slightly over 180-degree encasement. So the goal would be to get these patients to resection by either using chemotherapy or combination of chemotherapy and radiation. We still don't have enough data for IRE in this particular category. The far right is where you have the unresectable or the locally advanced pancreatic cancer group. So this is where there is a lot of studies that have been done using irreversible electroporation. So here's a similar animation for a patient with pancreatic cancer. As you can see, the vessels are encased the artery and the vein, and when you separate your 4 probes by 2 centimeters each and you start your treatment, here you get the treatment between probes 1 and 2, and then as you saw in the previous animation, this is how you would complete your treatment. So we're going to look at some technical aspects of the procedure by itself. You need general anesthesia to do this procedure. This cannot be done with conscious sedation. Some cryos and microwaves can be done. For IRE, you need complete muscle relaxation and general anesthesia. So this is your generation 3. So in the past, up to generation 2, you have to wait for you to complete the treatment and then go back and look at what we call as the treatment graph. In cryoablation, you're familiar, you can see the ice ball as you're treating the patient. With microwave and IRE, you do not have a mechanism to know what exactly is happening while the treatment is going on. But now with the 3rd generation, you can watch this live as the treatment happens. So just to quickly brief you about the graph, you start at a certain level and you want to see an upward slope of the graph as the treatment happens. That tells you that the cell is being electroporated and that more electricity is passing through the cell. So you want to see an upward slope and you want to see a delta of at least 15 to 20 amps usually. Sometimes we don't get it, so we increase the voltage if there is an option to increase the voltage, and then we try it again. Very rarely you will have instances where you don't see the delta, but as long as you've completed the treatment, I tend to stop it. So that's not a common thing, that's pretty rare. Patient positioning, many of these procedures could take anywhere from 2 to 4 hours, so you don't want your patient's hands stretched above their head, which could lead to brachial plexus injuries. So We kind of use a low-tech method. We put some pillows or towels under the patient's arm, we cross it across, and then we tape it, and thereby we prevent the risk of brachial plexus injuries. The nasogastric tube plays a vital role in patients with pancreatic cancer. This is something we routinely use in all our IREs of the pancreas. It serves two purposes. One, once the NG tube is in place, this is done after the patient gets general anesthesia. We inject oral contrast through that so that we can delineate the stomach and the small bowel. And the NG tube is also put to suction after the ablation is done. Typically, when you have a tumor in the head of the pancreas and you ablate it, you're going to have some swelling and edema that could cause a risk of outlet obstruction. So when you have the NG tube and you connect it to suction, you avoid that problem. Plus, when you're doing the ablation, it helps you to see the margins of the tumor better. I wouldn't say perfect, but definitely much better than not having the NG tube. So that is something which we routinely place in all our patients. So once the NG tube is in place, we mark the patient's position, and then we get ready to get patients prepped, and then we get started. This is the IRE probe itself, and this is labeled on both ends, one near close to where you're going to hold it, and the second label is where the probe is connected to the machine. These are 19-gauge diamond tip needles. They're pretty sharp, but they're also pretty thin. So they're pretty flexible, so you can torque the probe, unlike microwave or cryo, where the probes are a little more rigid. So the black lever there, when you press it down and pull back, you're going to expose the active tip. And that can be in increments of 5 millimeters. So depending on the depth of the tumor, you're going to increase the active tip, and the maximum I've used is about 3.5. Probe placement, this is again another low-tech method that we use. The probes, I use CT for all my procedures. If you're using ultrasound, you can watch in real time and push your probe in without a problem, but when you're using CT, you need to check whether the plane is accurate where you're going. So since the probe is heavy, it can wobble. So we use these blue towels, we roll them up and put them at the back of the probe to support it. And then this way you're able to advance the probe just maybe even a centimeter, and then scan again to make sure that you're in the right plane before you continue to advance the probe. The treatment with complete muscle relaxation, when you confirmed your position, you're ready to start treatment, you want to check with the anesthesiologist. They use a twitch monitor to check whether the twitches are between 0 and 1. That tells you that you have adequate muscle relaxation. And once you've done that, you turn off the twitch monitor, because otherwise it can interfere with your AccuSync. And then once you turn it on, you're going to see the movement in these probes. You see this more in patients who are a little skinnier and if the tumor is closer to the surface. But you will see motion in the probes, which is not something you will see with cryo or microwave. So this is something you will get used to when you're doing this procedure. Probe removal, when you're performing thermal ablation with RFA microwave, you have the option of track ablation. You can ablate the track as you remove the probe. Whereas with IRE, you do not have that option. So what we've been doing is using closing the active tip of the probe. Once we're done with the treatment, you can press down on the same lever and close the active tip and take it out now. So therefore, you reduce the risk. We've not had a case of track seeding since we started doing this, using this technology. I don't know. Sorry. What are some of the complications you can expect with IRE of the pancreas? Bleeding is one of the things that you should be aware of, and be careful when you're doing the procedure. Like I said, it's a very sharp tip needle. The technology is safe near blood vessels, but with the act of placing your probe, if you're not careful, you can hit any of the blood vessels, and that could cause bleeding. As you see in this particular case, where the second image, we're advancing the probe, and in the third image, you can see that there's a hematoma right under the anterior abdominal wall. So this patient was managed conservatively, but there are case reports of patients who've had pseudoaneurysms and bleeding, active bleeding, during the procedure. Pancreatitis is something you want to discuss with your patients. This is something you would see more commonly in patients who've not had radiation. Patients who've had radiation, the risk is pretty low. In non-radiated patients, you can see pancreatitis. Usually you have an elevation of the amylase and lipase, and you just keep these patients NPO, and the numbers trend down to normal, usually within 24 to 48 hours. So who would be an ideal patient for percutaneous IRE of the pancreas? Somebody with stage 3, diagnosed with biopsy and ECOG performance status of 0 to 1, and you have a safe access to reach the tumor, and somebody who's completed at least 1 line of chemotherapy. And in our practice, our maximum that we're using currently is about 3.5. I'll talk about this in our study that we did in 2017 that we published. We were treating tumors bigger than this, but now we've kind of restricted it. We found that patients under 3.5 had a better survival benefit. Once you go past that size, the benefit is not that great. So very quickly in one slide, we look at the protocol of the procedure. We see these patients in clinical consult in the office, and we also make sure that they have a metastatic workup because we want to make sure that they're not moved to stage 4. So all your imaging and labs should be within 1 month of the initial consult. And patients also see anesthesia because it has to be done with general anesthesia. You want to make sure the patient does not have a cardiac history of arrhythmias. These patients are admitted overnight after the treatment and they kept NPO after the ablation. Do not remove the NG tube, it needs to be put to suction, and you wait till the morning when you get your amylase and lipase. If they are normal, then you can remove the NG tube and start the patient on clear liquids and then advance as they tolerate it. And usually you can discharge the patient the day after the ablation or after the second night. If the patient's elevation of amylase and lipase is noted, leave the NG tube in and they continue on ice chips, and you wait till the numbers drop. Like I said, usually it's about 24 to 48 hours. Follow-up, these patients are seen in clinic and with MRI with contrast and diffusion weighted sequences at 1, 3, 6, 9, and 12 months. We also get a PET scan within 24 hours after the treatment that we use it as a baseline. We do that within 24 hours so that we get it before the inflammation sets in. And then we repeat the PET scan at 3 months. Every time we see the patient in the follow-up, we make sure that they get their labs and the tumor markers. So some case examples here. This was the very first case of percutaneous pancreas IRE that was done back in 2010. This was a 65-year-old female who had previously been treated with chemotherapy and radiation, and she had local tumor recurrence. She had encasement of the celiac axis and the superior mesenteric artery. And we approached this from the anterior aspect and with 4 probes bracketing the tumor. And we did have a significant hematoma that formed right under the anterior abdominal wall, as you can see here. We were going to stop it, but our surgical colleague advised us to continue, and I'm thankful to him for that. We completed the treatment, patient's vasculature was normal, and you can see the gas in the treatment zone. That is normal, that is secondary to hydrolysis. Anytime you do IRE, you're going to see that, and that usually disappears in 24 to 48 hours. Patient was then watched for about 4 months without progression, and then she went down to get surgery. This time they were able to get an R0 margin, and patient then got an extra 5 years after this. Again, this is not a typical case, but she had a really, really good outcome after the IRE. Here's another more recent patient with the locally advanced pancreatic cancer. This is before we are planning our trajectory. We make sure we give the patient contrast and to see where your blood vessels are. And it's also good to have a pre-procedure PET. As you can see in this particular case, this patient has, let me see. So you can see the hot area on the PET scan, and this is a snapshot of the same PET. And here we're placing the probes. Again, when you're placing probes with CT, you're not going to have the advantage of contrast. So if you have a dual monitor system, that's going to be very helpful. You can play your, you can have your contrast enhanced images on one monitor and then use the other monitor for your needle placement. I'm sorry, I don't know why this video is not playing. And then once we're done with the treatment, we do the post again here. Again, why this video is not playing. We do the post with contrast to make sure that the vessels are all intact, which was in this particular case. And here's the post PET scan on the patient, which in the snapshot you can see that there is no uptake there. So there you see it. That's the short video of the PET scan. On the right you see the snapshot. So here's the comparison of the pre and post PET scan of the same patient. And finally, this is another patient who was considered unresectable, locally advanced pancreatic cancer. Patient was an athlete in good performance status. And we treated this with 4 IRE probes using a transgastric approach. And whenever you place your probes, you do the 3D reconstruction to make sure you confirm the distance between the needles. And then this is the immediate post of this patient with contrast. Again, the goal is to make sure you don't have any active extravasation or bleeding can happen after the treatment. So when you look at the CT of the patient, you don't see a major change. You see a hypodense area in the CT after 1 month. But when you look at the PET scan of the patient, this is the pre-PET scan before the treatment, and this is the post. You're going to see a pretty dramatic change in this patient's PET scan. So he's been doing well. We've been monitoring him since 2016. Again, this is a very unique case. He's not had any local recurrence, and they've stopped chemotherapy on him for a few years now. And he continues to play sport that he does. Imaging changes, we talked about changes in the liver before. In pancreas, you don't see that very often. There is one example where I did see it. On the left, you see the enhancement of the tumor right next to the biliary stent. This was treated with 4 probes, and then here, 14 months later, you can see there's no enhancement of the area and reduction in size. Now let's look at some of the data that has been published in percutaneous IRE. There's data on the surgical approach to this. Was initially started by the surgeons with the open technique. The first human experience was published from our group back in 2012. This was 14 patients. We managed to downstage 2 of those patients to resection to get to R0 resection. We followed this in 2017 with a series of 50 patients with locally advanced pancreatic cancer that was treated with percutaneous IRE. The primary objective of the study was safety, and the secondary objective was to determine overall survival. Again, this was a retrospective study, so all of these patients had previous chemotherapy, and 60% of them had radiation. And the median time from diagnosis to IRE was 11.6 months. Again, there is one of the criticisms of the study could be that this was a selected group because it's retrospective, and these patients had good DNA because they had already come up to 11.6 months after just treatment with chemo and IRE. But even then, the median overall survival that we got was more than double than what you would get with conventional treatment, which was a very healthy number of 27 months. And from IRE, we got 14.2 months of survival benefit in these patients. When you compare this with the largest surgical group, which was from Dr. Rob Martin's group, and this was a multi-center study on the left, where you see two lines on the Kaplan-Meier curve, because one line represents patients who got de novo IRE, and the second one is patients who had margin accentuation with IRE. Our numbers were actually very similar, slightly better with the percutaneous group, where we had 27 months as opposed to 25 months with the surgical data. The same percutaneous data has been replicated in other centers. This is from the UK, Dr. Lean and Dr. Wasan. 75 patients who were studied retrospectively, and this was with percutaneous IRE, and the median overall survival and progression-free survival was 27 months and 15 months, and 4 patients were downstaged to R0 resection. Another study from Japan, this was a smaller study of 8 patients, and this was 4 of them were treated percutaneously and 4 of them were treated open. And once again here, the median overall survival after IRE was even better than ours, was 17.5 months, and the overall survival from diagnosis was 24 months. 4 of these patients had 4 major complications in 3 patients, but no patient deaths. So when you compare 4 of the major retrospective, 3 of them are retrospective, 1 is prospective studies which were done in percutaneous IRE, you can see that there is a clear signal to improvement in the overall survival of these patients compared to the 11 months that you would typically get. And the most recent data, which is a prospective phase 2 study, is also from Amsterdam, from Dr. Meiring's group, where they looked at the use of percutaneous IRE in both locally advanced pancreatic cancer patients and those who had local recurrence in the surgical site. And they had a target overall survival number that both these groups had to meet 11.6 and 14.9 months. The results showed that both the groups met the endpoint, and the patients with LAPC had 17 months overall survival, those with local recurrence had 16 months. So which is also very encouraging. They currently have 2 studies enrolling. One is the Crossfire, which is a randomized study looking at chemo-IRE versus chemoradiation, and another study, which is the PANFIRE-3, looking at the immune response. In the United States, we finally got the approval to have a FDA-approved study for the role of pancreas IRE in the management of the cancer. And so this study has both an RCT and a registry. The registry will also has a control arm where patients who are just treated with chemotherapy are enrolled. The study is currently enrolling. The registry has had a lot more success than the RCT. So future directions, we're looking at what happens to the immune response after treating these patients with IRE. There's been work done with that, comparing the immune response post-IRE and cryo from Wisconsin. That was published in JBIR, and this is in Nature, which was published from the MD Anderson group, where they found in a mouse model when they used IRE, they were able to reverse the resistance to immune checkpoint inhibitor blockade in pancreatic cancer, which is another encouraging sign as to where this technology could play a role in modifying the management in pancreatic cancer. To summarize, the prospective and retrospective studies have now been done over the last 10 years, and they've established the safety. Multiple studies have shown that there is a survival benefit using this technique, and the registry and the randomized control trial will help further define the role of IRE in pancreatic cancer. And I would just like to take a minute of your time to invite you to Miami in January. We have our 12th annual Congress called Spectrum. It's a multidisciplinary Congress. We have about 90 faculty members from around the world. And the registration for any trainee is free. And there's also a travel stipend provided. You can find the information on the website. So it will be a good meeting in case you're interested to attend. And with that, I'd end my talk. Thank you very much. And I'm sorry about the glitch with the computer. I apologize, and happy to take any questions.